has clinical ramifications, but it also has real legal ramifications. So let's start doing this if it works. My aim is not to tell you about like the mechanisms of the injury or pathophysiology, because you all know about like the treatment of the head traumas and how to recognize them. But my aim with this talk is to bring awareness. So therefore, I really thank you for including this topic in this meeting. And I also wanted to help recognize or suspect at least abuse, to encourage all of you guys to act on it appropriately, because in our busy lives, especially when you're a resident, you may not really stop and think that this is a child abuse when you see a patient with a head trauma and we just go by. But sometimes, don't forget, these babies, these kids, when they come to the ER, we're the first ones or maybe the only doctors for them to see. So therefore, I think as neurosurgeons, we don't have to take the front line, but we still have to be aware of the condition, and we should discuss about education and prevention. One thing that I want you to take out of this, talk, if nothing else, if you see something and if you're suspicious about a child abuse, please say something and do something about it, because the next time that baby may not have a chance. It was not until after 1874 when the New York Society for the Prevention of Cruelty for Children was founded. Actually, before that, it was just like an orphan, 10-year-old orphan girl in New York City, Mary Ellen, who was physically abused by her adoptive mother in 1873. The neighbors saw, and then they didn't know where to actually report. So they reported to the American Society for the Prevention of Cruelty of Animals. It wasn't until 1874 that Prevention of Cruelty to Children as foundation for it was founded. So, it was lacking behind and nobody was doing anything about it. So the WHO, the UNICEF actually defines the child abuse, not only child abuse, inflicted, not only physical, but also mental abuse and injury to a child, and neglect or a negligent treatment of a child, and exploitation or sexual abuse, and abuse to an immigrant child, and also, the condition of the children in conflict, neglect of the children in the conflicting zones. So the definition is very broad. But when we use the terminology, there's a little bit of a confusion. When you use child abuse or child maltreatment, that is a general term for injury to a child, such as a physical abuse, neglect, a sexual abuse. When we talk about shaken baby syndrome or shaking impact syndrome or battered baby syndrome, it actually implies a specific mechanism. It doesn't really identify it completely. It's a specific type of non-accidental head injury. When we say non-accidental injury or non-accidental trauma, as stated by American Academy of Pediatrics in 2009, it's a general term for inflicted injury to a child. Again, when you say abusive head trauma, it's a head trauma, inflicted head trauma to the head. In 2012, CDC, the United States Center for Disease Control and Prevention, made guidelines and defined child abuse or non-accidental head trauma is an injury to the skull or intracranial contents of an infant or young child less than 5 years of age that is due to inflicted blunt impact or shaking. And that was the definition, and that is the terminology that we use. Throughout this talk, we will use either abusive head trauma or non-accidental head injury to define it. This definition excludes the unintentional injuries caused by neglect, such as if you leave a gun out and the children takes it and injures themselves. That is not a child abuse, where I feel like it should be. So we do not know the incidence. What is the incidence of it? We do not know. What we know is it varies from community to community, region to region, and amongst the countries and amongst the cultures. The most studies come from developed countries such as United States, Canada, Switzerland, England, New Zealand, Australia, and those incidences have not changed over the decades. Sometimes in lower or middle income countries where we call a child abuse in United States may not be a child abuse. A little slap or a little shake for punishment may not count as a child abuse in some of the cultures. But don't forget that the violence may take place in homes, schools, orphanages, residential cares, and refugee camps, prisons, and especially like in workplaces where children are used for work as workers. But what we know is that the most affected age group are children under the age of 5 years, mainly the children under the age of 2 years. In most studies, boys were found to be a little bit higher risk than girls. However, the recent studies say that the girls are at risk as equal to boys. So there's no difference anymore. Globally, about more than 500 million children suffer violence of any sort every year. When we look at actually the incidences in developed countries for non-accidental head trauma, it's 10 to 30 per 100,000 infant per year. It doesn't sound much, but when you look at the ones that are underestimated or underreported, I think it is much higher than what we have reported. The incidence in the US, was reported by annual reports in 2017 and 2016. I don't have the recent reports as of now, but nearly about 700,000 children are victims of abuse every year. Head trauma is the lead cause of child abuse deaths in the US, and the number of children dying under the age of 5 years is mostly dying because of the head injuries and accidents. Young children less than 1 year of age suffer the most in the United States, and you actually see more than 2,000 deaths a year because of the child abuse or head trauma. About 18,000 permanent disabilities happen every year. Victims are the perpetrators are the parents or the caregivers most of the time. What are the risk factors? Why a mother or a father is actually abusing their child? Unfortunately, it comes to low socioeconomic status and money. A single parent, a single young parent who does not have any, a job, who doesn't have the socioeconomic means, who does not have higher education, is more likely to abuse his or her child. A premature birth, an increased number of siblings at home, a male infant is a risk factor. Mental illness in parents should be considered that we actually omit. Substance abuse in parents, a male caregiver who's at home, who's out of work, is actually a risk factor. I added a pandemic in this, slide because unfortunately I was listening to a new, BBC report as well. During the time of COVID, when everyone is at home and everyone is stressed and they're out of work and fathers are at home, the rate of domestic violence, the incidence of child abuse has increased over the last few months because of the pandemic. So I added it there. So mainly it's the socioeconomic status. Dr. Barr and his colleagues did a study in 2014, and the main risk factor that they found was a stressed parent with a crying baby. And they looked at it, and the longer the crying period, the more likely that the parents will abuse their children, especially those babies under 1 year of age. They cry a lot, so therefore it is not surprising that a crying baby is a risk factor. And fathers are responsible in about 37% of the time. Mothers are 12.6% of the time are the responsible perpetrators. But when you look at it, it changes from country to country. When you look at the, developed countries as well as lower and middle income countries, mostly an adult acquaintance of the family and the child is the perpetrator. And usually that's a male. As I said, we don't want to go into mechanisms of injury, but I should mention that the most likely it's the multiple mechanisms are involved in the child head traumas. There are a lot of studies. Dr. Duhaime in 1970s, 1987s and 90s did studies. Shaking, per the perpetrator's confession, is the most common mechanism of injury. You hold the baby with a big head, where the head and neck is not proportional. The head is big, you shake that baby, and the head accelerates and decelerates with the shaking and the brain in it, which then causes diffuse axonal injuries, tear of bridging veins, and injury to the axons then starts the cascade of apoptosis, exocytotoxicity, and secondary injury with hypoxia and ischemia. Don't forget that these babies also are more likely to be, victim of repeated trauma, repeated impact, which then brings the second hit, like we always talk about concussion. The impact, which is like slapping or pushing or, hitting the head, is about 17 to 20% of the 29% of the times. But again, it is most likely multiple mechanisms that is involved. Presentation is very important, and that is the part that we unfortunately do not spend a lot of time, because in our busy schedules, I've been a resident, my residents do not have enough time to sit down to look at all these or get a big history. But the presenting symptoms to us is classic head and spine injury. The history of the events is more important. Changing history, like in a conflicting history, is very important. A detailed examination, which sometimes we lack to do, provide clues such as bruises, such as abnormal patterns of injury. Something has to trigger you. And then the best and most helpful history that triggers everyone is the story that was taken at initial contact with the caregivers. So that is very important, that you actually get a good history where you're suspicious about a child abuse. The clinical symptoms may be decreased level of consciousness, irritability, vomiting, poor feeding, failure to thrive, malnourished as because of a neglect. And apnea and respiratory difficulties are very common presentations in non-accidental trauma because of the breathing of the spells, or of course because of the hypoxia, ischemia, or brainstem injury with the shaking and impact. But one thing that should trigger you and should make you suspicious about a non-accidental trauma is the seizure at initial presentation. Seizures are very common in non-accidental trauma. It's about up to 69% when compared to accidental traumas, where it's only 12.8%. Of course, we look at the radiographic findings, and there are findings that should trigger you in the radiographic images. As neurosurgeons, we go to CAT scan, we go to MRI, and like in a heartbeat, right? And there are signs that should trigger you, should make you suspicious about a child abuse in radiographic images. This is a table from Dr. Adoma and his colleagues in 2019. And what they found is actually the subdural hematoma is much more common in children with non-accidental head injury. The others are the same. But when you look at the CAT scans, look at a few things. Findings of mixed density subdural hematomas in imaging studies are much more suspicious of non-accidental head trauma. It occurs about 67% of the non-accidental head trauma patients. Interhemispheric subdural hematomas, posterior fossa subdural hematomas are most likely associated with the abuse. A chronic subdural hematoma, like you see over here in a baby who's malnourished, who's irritable, who's failing to thrive, who's being delayed, should trigger concern. When you come to skull fractures, everyone has x-rays to look at skull fractures, and CT is available. When you look at a baby's head, a skull fracture, look at it. Is it complex? Is it multiple? Is it involving more than one bone, which are more likely to be related to a non-accidental trauma? An isolated skull fracture in the parietal region is probably not a non-accidental trauma, but multiple fractures, non-parietal fracture, a complex fracture with the impact may be more related to the non-accidental trauma. Black brain is a rare finding, but it's the real finding in babies with non-accidental trauma that you see more often, where there's no injury, accidental injury that you can pinpoint, and you see this kind of images where the brain is black. There is also subdural, there's loss of sulcal gyral patterns. You have to be suspicious about a non-accidental trauma. It is typically seen with subdural hematoma. It is associated with higher mortality. Survivors are at high risk of neurological deficit, and pathology is not well understood. We feel like it's a combination of hypoxia, ischemia, secondary injuries in addition to the trauma. So this should trigger you. These are, some MRIs of my patients, my own patients. It's our practice that we do an MRI of the brain and MRI of the spine for all the patients that come to us that are suspected of having a child abuse. We have the luxury of having an MRI, so we see all these patterns of mixed density subdural hematomas bilaterally. We see like laminar necroses. We see like hypoxic ischemic areas. And then one thing that we actually missed, and it's been recently reported that it's more the spinal injuries. Now we forget about the spinal injuries in a non-accidental trauma or in a younger children because they don't really present with like a spinal cord injury very often. But newer studies show that the spinal injury in a non-accidental trauma, especially in the upper cervical spine, is more common than we initially thought. And one study shows about 24% of incidents, but it's important that you look at the spine because findings in the spine may be missed. You may see like ligamentous injury, edema at the craniocervical junction or craniocervical junction ligaments, or subdural, subarachnoid blood going down through the spinal canal, and images should trigger you. If you don't have anything else, no CAT scans, no MRIs, nothing, you probably have an ophthalmoscope. I think every neurosurgeon, it is difficult and it's difficult for me, but every neurosurgeon in training should know how to use an ophthalmoscope in the very simplistic way. If you don't have anything, you have an ophthalmoscope more likely, or an x-ray. This is one case where you should not really worry about radiation to the children because the benefit is higher than the risk. You have to do a skeletal survey when you're worried about a non-accidental head injury or a child abuse. It is simple. You can access it anywhere. It's cheap. And the skeletal and long bone injuries are up to 75%, seen up to 75% in patients with non-accidental head trauma. And like an old rib fracture, old bone fracture should trigger you. And this is easily recognizable in x-rays. The retinal hemorrhages, forget about like the retinal hemorrhages because of high ICP, because of birth trauma, because of like mild injury. It is different in non-accidental head traumas, right? About 53 to 80% of the time you see retinal hemorrhages when compared to accidental head injuries. The retinal hemorrhages involve multiple retinal layers. They have like their pre-retinal hemorrhages, they're more extensive. They go to the periphery in a child with, non-accidental head injury. And the positive predictive value of a retinal hemorrhage like such this, as you see in this image, which belongs to one of my patients, is about 89.4%. So it's pretty high. So you can take an ophthalmoscope and look at an eye if you can, and at least try. So a lot of groups try to do clinical prediction rules to help, especially emergency room physicians, to recognize head trauma. They were like, predict AHT, predict in 2018, 2013, and recently revised. But what they look at the clinical criteria that we've been, talking about, such as head, neck bruising, seizures, apnea, rib fractures, long bone fractures, to determine if this patient is as a victim of a child abuse or is an accidental trauma. But those clinical prediction rules have higher sensitivities, though they are supplementary to diagnoses and an aid for physicians to further investigate. They should be like, flagging, they should be like alarming findings, but unfortunately there's not a big score that we can use reliably, even though their validation have been tested. But the main and the most important thing is your suspicion. If you say something and do something about it. The treatment is not different than any other head and spine injuries. It depends on the severity of the injury. Surgery is indicated where there is significant mass effect. It may be a small craniotomy, craniectomy, subdural shunt, subdural, taps for chronic subdural. But the prevention of the secondary injuries, such as hypoxia, such as seizures, are very important, and it actually, provides better outcomes. Seizures or subclinical seizures are something that you should keep in mind in these babies. So if you have an EEG access, please hook these babies up to an EEG monitor and start your anti-epileptic medications. The recent studies to prevent like early seizures, if there's no seizure, with phenytoin or Keppra, are not like, high level, but especially in a baby who has loss of consciousness, who has really injuries to the brain, keep in mind that seizures can cause more trouble and can occur more in non-accidental head injury. So do your prophylactic anti-epileptic treatment. So I want to actually credit my partner, Dr. Albert, and our resident, Dr. Palmer. They do a little mini craniotomy, procedure bilaterally, especially with our patients with bilateral chronic subdural hematomas. And with these little mini craniotomies that they do on either side, they had actually much more of a treatment for, less failure of treatment, less accumulation of subdural hematomas, chronic subdural hematomas in the long term for these patients. When we look at the outcome, about 1/3 of the patients are in good condition, but severe disability may occur up to 33% of the patients. Moderate disability is less, and about up to 7% of these patients have real delays in a vegetative state. The rate of death was reported up to 19% in one studies, which is much higher than accidental injuries. Visual dysfunction, epilepsy can continue. About 10% of the patients are long-term disabilities. But don't forget, quality of life falls about 15% even with a mild abusive head injury. And that is the most important thing. And that is the thing that causes a lot of economic impact on the society, not alone in this child's life. When you look at the reports by Feng and et al. From 2012, it was about $210,000 per one living victim in the USA that we spend for medical care, lost productivity, child welfare, criminal justice, and special education and needs per year. So it's about $124 billion that we spend on abusive head traumas or abusive injuries to these children. When you look at the total economic burden in 2018 in United States, right around the crisis, we were spending $124 billion for patients that suffered from abusive head injuries. If we can prevent this and do not spend that $124 billion, we can actually send 1.7 million children around the world to higher education. So we're spending money where we can spend and channelize it to a better cause. So the prevention becomes very important. They did a very small study in Western New York in 2005 by educating the parents, by providing them with leaflet, videos, and educational posters, and by asking them to sign a commitment saying that, they're not gonna, injure their patient. They were able to prevent non-accidental injuries. They had seen 47% decrease in their incident in this Western New York county. And when they looked at the cost, it was $10 per infant that they had to spend, total of maybe $177 per year when compared to $2,010 for one infant with the child abuse. So prevention is actually much cheaper than treating these patients with lifelong disabilities. We looked at our numbers in 2007 at ACH here in Arkansas, and we had 53 cases of abuse. I have to admit that we are one of the states where the child abuse is really high. We had 24 had some level of permanent injury. We had 5 patients that died. Therefore, we have very valuable faculty in our departments, especially with anesthesia and pediatrics, that look at prevention at the primary level, which is prevent cases before they're occurring. Dr. Daly, who is one of our faculty members, look at predictability models in our state of Arkansas, where we actually see most of the cases. They have this large map that they're offering to everyone. I think they will be offering to internationally and nationally, where you can predict where those child abuse cases will occur. And unfortunately, those are mostly the socioeconomically low income places in our state. Secondary, prevention is important. That means prevention of additional cases from occurring. Tertiary is minimizing the long-term damage to these infants, including physical damage as well as mental damage. What we do in Arkansas with our legislation that was put in in 2011 is the act that ensure that each woman who gives birth in a hospital or a freestanding birthing clinic receives educational materials. So they have to get educational materials before they're discharged with their babies. We do have visiting nurses to high-risk families. You know, they go to our nurses go to teen mothers. They go to like families with a history of substance abuse or domestic violence. And we do have guidance about normal infant development. We teach them. We have the luxury of having all these resources, but you know, wherever you are in the world, you have one of your nurses, like, you know, giving normal education to a mother or to a, you know, young parent, to a father, you know, can talk about these issues easily. It just takes 5 minutes or 10 minutes. You don't have to have videos or, you know, pamphlets or education booklets, but even talking to the families before their discharge, by a midwife, by a nurse, by a physician, can prevent these injuries in the long term, especially, you know, where family within the high risk families. So you know, a crying plan, such as like, what do you do when your baby cries too much? You know, don't lose your temper. So those are really basic teaching to young parents, especially, which can be done like by just 5 or 10 minutes talking. Which is most important, especially in our country, is access to affordable daycare and affordable resources that, unfortunately, we're not able to provide to everyone. So in Arkansas, you know, it's mandatory to report. As I said, if you see something, I think we have the obligation. You know, we shouldn't think that we're not the front line. We should think that this baby's maybe the only chance, or like, you know, all chance to actually be reported or be seen or be heard. So if you see something, please report it. You know the law wherever you are, know the law in your country, in your state, in your city. What should you do? Do you have like a, you know, a reporting line? Do you have an anonymous line? Do you have like, you know, somewhere that you can call and report these events in your hospital, in your community? You know, we in our practice at Arkansas Children's Hospital, admission to hospital, and consultation with our team for children at risk is, you know, a very common practice for children under the age of 2 years. I have the luxury of having a social worker, a pediatrician who's trained at child abuse. But even if you don't have that, I think if you're worried about a child abuse, you have to report it. You have to do something about it, because that baby may not have a second chance. The reporters of child abuse does not have to be doctors or physicians or neurosurgeons. It can be any medical profession, anyone in your team, your nurse, your nurse technician. Somebody raises a risk of a child abuse in that patient, you should not dismiss it. You should actually look into it. Even one person, it takes one person to be suspicious about a child abuse for us to trigger the, you know, cascades, to trigger the other services. So it is very important to report, you know, it, because as I said, about 31% of these cases are missed in the, you know, prior diagnosis final to their very disabling or death. So it's more commonly missed where you expect the least. You know, we know that 30% of them sought non-routine medical care previous year. 19% of these babies sought medical care in the previous month. So it's easily missed. So, and when you miss it a second time, the hit may be much more severe. In our country, in the United States, we always, you know, get into conflict with you know, of course, the legal system. You know, there are a lot of arguments. We have to go to the courts to defend our, you know, findings, or if there's a child abuse case that is brought to the court, then you have to know what to do. So we've seen a lot of arguments. When you look at the literature, there's a lot of arguments against accidental head trauma. You know, don't listen to them. You know, when you look at the literature, especially the seminal paper that came out in 2018, puts a distinctive, like, you know, criteria for child abuse. Again, if you're suspicious about it, please, you know, report it. So don't listen to, like, you know, shortfalls causes like non-accidental head injuries, lack of oxygen, birth trauma causes like retinal hemorrhages, cerebral venous thromboses or aneurysms, you know, causes injuries that may mimic non-accidental head trauma. you know, children does not have an aneurysm as, you know, in a high incidence as adults, right? It's very rare in children. No, there's no, you know, you hear these people say, oh, no, there's no evidence that shaking can cause serious injuries. A shaking in a small baby with a big head, with like an adult shaking and impacting, can cause a big injury. So I think there are arguments that we're diagnosing child abuse and therefore, like, you know, separating babies from their families. But it's very important that if you have suspicion, to look into it at least, and to bring it to the authorities that may further evaluate for the safety of that baby. Again, I was going to talk to you about this consensus statement that was published in 2018 by Dr. Chaudhry et al. And this was endorsed by multiple societies around the world, not only in the United States. And that consensus statement says that there's absolutely, you know, a disease, a syndrome that is called child abuse. So child abuse is not unreal. It is real, and the arguments against it are, you know, are not valid. So that is a paper that you should read about it. Again, when we look at the prevention strategies, identify a pediatrician in your hospital, because I know we have, like, you know, a lot of busy schedules. You know, we should not be the ones maybe to do this at the front line, but identify a pediatrician who's willing to work with you, who's willing to take responsibility for these patients, who is willing to actually, like, you know, form a team. A social worker, if you have an access to a social worker, please involve them in your team. A multidisciplinary approach led by a pediatrician can save lives. And consider non-accidental trauma when you see a baby with like an abnormal, like, findings, a little bit of a bruise, the story doesn't make any sense. So, you know, please, if you see something, if you're suspicious about something, say something about it and do something about it. So my take-home messages before I leave you is, non-accidental head injury is preventable with appropriate education and support of especially young parents, which can be done by anyone. Any healthcare professional. The cost of parental education is proven to be less than treating a child. Don't forget that we have children who are hungry. About 20% of the American children are, you know, hungry or poorly, you know, fed. So we can send or provide, you know, resources for them where we, you know, we can channelize our resources to them rather than spending it on non-accidental head traumas. Always consider child abuse as a cause of head trauma, especially in children under the age of 2 years. The role of pediatric healthcare professionals and neurosurgeons is not to treat these children only, but also recognize the possibility of maltreatment. So be aware of it. Do not hesitate to contact child abuse pediatrician if you have one, or protective services if you have one. Report it appropriately. I would like to acknowledge my team here, and I would like, you know, thank you everyone. I would like to show these images. Like, these babies are all having fun, but when you look at the big picture, these are actually our neglect. Like, you know, they're all in one, you know, motorcycle here. They're like by the water here. They're like outside by the way here. They're having fun. These are my photos, but, you know, in the big sense, they might be just child neglect. Again, this is a very controversial topic. Thank you so much for letting me talk about it. I think I'm on time. Thanks, Mania. I cannot hear you.
Thank you. You can hear me now?
Yes, 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 yes.
Thank you. Thank you very much. This was a very important and complete lecture that covered all the aspects of the non-accidental injury, but Naren asked me to skip the questions for now because we're a bit over time, and some have already been answered during your talk.
There will be what you call questions on the, there are lots of questions on the chat box.
Yeah, right.
Okay, so, do you want me to go ahead and answer them?
Please. Oh, no,
please.
No, type and answer them for me, please.
Okay, we'll do. Well, I got to go from me. Thank you so much for letting us talk about this topic.
Thanks. Thank you very much for the
Thank you. Thank you. So we pass this to Gurish.
Hey, yeah, thank you. It gives me great pleasure now to invite Professor Goel. He's very well known to all of you. It really doesn't need any introduction, but just for the general population that is about 1,000 people listening today, Professor Goel graduated from the Upstate Medical University in Syracuse. He's, of course, the professor head of the department at the KEM Hospital and SET-GS Medical College in Mumbai. He also has offices in the States, in Nevada and North Carolina. Of course, his main interest is spinal surgery, but he's also a master surgeon in pediatric surgery, acoustic neuroma, skull-based surgery. And he has contributed to the World Fund of Knowledge in Medicine by editing a number of surgical journals, particularly spine, and published a number of chapters, co-authored books, number of publications. I think I'll spend a whole day talking about all the things that Professor Goel has done. But of course, he is much better known for his groundbreaking investigations in craniocervical surgery. And today he is honoring us by delivering his talk on craniocervical instability. My great pleasure to invite you to deliver it.
Thank you, Girish. I must say it is my great honor and great privilege to be able to talk to all of you, particularly to my dear friends, Naren, and of course, Girish. And also I was listening to several lectures on craniostenosis. I think you are having one of the world's best centers on this subject, to say the least. I am going to talk to you on pediatric craniovertebral junction instability. And I hope I will be able to deliver some wonderful messages. Craniovertebral junction is a complex subject. I will ask you one question before I start. If this child comes to you with a short neck and with some symptoms in the limbs, what is your diagnosis? And with this imaging, with this bifid here, what is your diagnosis and what is your treatment? I must say in the beginning that this child has one issue, and that issue is atlantoaxial instability. And this patient needs atlantoaxial stabilization. As I go ahead further on this subject, I would like to elaborate as to why I am saying atlantoaxial and why I am saying this child needs stabilization. And I have to say this child needs stabilization for sure. There's no discussion, unless the child is absolutely asymptomatic and you want to hold on. But if you are confident and you have the information about how to do selective stabilization of the atlantoaxial joint, this child needs stabilization. Craniovertebral junction is quite a majestic joint. Occipitoatlantal joint is one joint and atlantoaxial joint is the other joint. Occipitoatlantal joint is the most stable joint of the body, and atlantoaxial joint is the most mobile joint of the body. When it is most mobile, the articular surface is round and flat. The possibility of instability is the most. So most mobile and most unstable. I have no hesitation to say that atlantoaxial instability is the most common instability of the entire spine. I have no hesitation to say that atlantoaxial instability is the most under-recognized and under-treated clinical entity, without any confusion in my mind. When you say craniovertebral junction stabilization, it means atlantoaxial stabilization. Occipitoatlantal instability is completely rare. It is absolutely rare. This joint is like a solid joint and it doesn't give way, occipitoatlantal. On the other hand, this is a very flimsy joint, mobile joint, and the possibility of instability is quite high. Facets are the fulcrum of all movements. Transverse process of the atlas is the biggest transverse process of the entire spine. Spinous process of the C2 spinous process is the biggest spinous process of the whole spine. Facets, see, one facet is like as firm, as solid as a tooth. You just cannot, you put a hammer, you will not be, hardest bone of the body. Fulcrum of movement is the facet, and the movements of the craniovertebral junction are executed in the facets. So facetal stabilization is the answer to atlantoaxial instability. So we introduced this technique in the year 1987. And these two papers, those who are in this business, of course, know these articles, one screw in C1, one screw in C2. And this was my first patient in the year 1988. Now over the 32, 33 years, I've been doing this process of atlantoaxial selective fusions. I have more than 2,600 cases with this selective, not occipital. Occipital bone fusion is not a technique which is an optimal technique. Craniovertebral junction stabilizations means atlantoaxial stabilization. My technique since 1987 involves opening of the joint, denuding of the cartilage, and introducing bone graft in the joint and subsequent instrumentation. So these are my basic steps. So those who have to do atlantoaxial stabilization, it is a dangerous, difficult, and quite a challenging surgical issue, particularly in pediatric age group. So if you have to do it, you have to complete these 3 steps before you do the instrumentation. So this is my youngest child, 8-month-old child. You see the atlantoaxial instability. You see the quite a mobile dislocation. You see the responses in the cord, and you see the stabilization. This is a very old patient of my, old means a young patient, but old in my series. This is another very small infant. So I have several infants in my series. You see the bones are not even formed, but the facets are very well developed and huge. In this case situation, when there is bifid atlas, these midline procedures are no good. Occipital fixation is absolutely no good. So if you know how to do this fixation with the facet, this gives you a fantastic result, and the child an absolutely new life. So many syndromic issues, as the many pediatric neurosurgeons in the audience know, that there are several syndromic children who have craniovertebral instability, and you must have seen that occipital to multi-level stabilization has been suggested. But I have to tell you that all of these children present with atlantoaxial instability, and they need selective focal atlantoaxial stabilization with fantastic new life to these children. This is a brothers having the same DMC syndrome, and you see the dislocation. There is the need for atlantoaxial stabilization in these 2 children, and you see the beautiful smile. Not only beautiful smile, but a new life and a new beginning to their life without any question. This is another child with spondyloepiphyseal dysplasia. You see the joint, atlantoaxial joint, in quite a distracted situation. There's no need to do anything to the subaxial spine. There's no need to do anything to the occipital bone. If you do include the occipital bone, if you include the subaxial bones, negative operation without any doubt, negative. If you have to give this smile and this beauty to this child, it is selective atlantoaxial in stabilization. This is another syndrome that you pediatric neurosurgeons are aware of. This patient multi-level. This is the atlantoaxial instability. Atlantoaxial stabilization is the treatment, and there is no other treatment. And you can give this beautiful smile on the doctor's face and on the child's face. This is another child with osteopetrosis, and he has come with hangman fracture. You have to have hangman fracture. if you have to treat, you have to have a complete anatomical information about the vertebral artery, which is high riding in this situation. And this patient needs only one treatment, and that treatment is atlantoaxial stabilization and a new life. You see another wonderful, handsome child and a more handsome doctor, maybe a little less. Down syndrome is a very common clinical entity for a craniovertebral junction instability and craniovertebral. In this Down syndrome, we have treated at least 40 or 50 Down syndrome children. Atlantoaxial stabilization is the treatment. Bifid C1, atlantoaxial instability, you see the impact to the cord, and you see the wonderful new life, absolutely new life in the evening of operation is a possibility. Down syndrome is quite a common issue with the craniovertebral junction instability. You see the deformed craniovertebral junction, you see the high vertebral artery. Open the joint, denude the cartilage, introduce bone graft, and then do distraction and fixation, and an absolute wonderful outcome. I was doing, you see, we described for the first time include occipital screws. And this kind of construct, we were the first one to describe this construct in the year 1988. And I included occipital fixation, C1 fixation, C2 fixation. But today I wrote this editorial in Journal of Neurosurgery Spine. Occipital-cervical fixation, is it necessary? I am saying for last at least 20 years, occipital bone has never been included in my fixation construct. But of course, for those who will not be able to do atlantoaxial stabilization, inclusion of occipital bone may be the only option, but you must remember it is an absolutely suboptimal option. And chances of these kind of fixation, the chances of failure are absolutely huge. And this kind of implant extrusion, this kind of hand problem, and several other issues can be there. I just want to show this patient who was operated elsewhere in quite a miserable situation. We removed the implant and did this fixation, and you see this handsome child having a brand new life. It is a occipital inclusion, in summary, is not an option in general. Fixed atlantoaxial dislocation was a common clinical entity that was understood by all craniovertebral junction surgeons. So this was one of my most fantastic articles where I said that fixed, there is nothing called fixed. You can open the joint and reduce the dislocation, and this was published as cover page of Journal of Neurosurgery. Nothing is fixed. Nothing is irreducible. Open the joint, manipulate the facets, and you can absolutely treat these patients. This is a patient with fixed atlantoaxial instability, and many children have this fixed atlantoaxial. We were very familiar with transoral surgery, transnasal surgery to remove this odontoid. So my dictionary, transoral surgery, is completely historic. Open the joint, distract the facets, and do realignment of the craniovertebral junction, and beautiful clinical recovery that you may observe very soon in the post-operative period. This is fixed anomaly, open the joint, reduce, and you do the fixation. This is another case of fixed. So this is not the case for transoral decompression. Transoral decompression is maybe an absolute negative operation, maybe a dangerous operation. I must tell you that I was doing quite a number of these transoral surgery, but for last 20 years at least, transoral surgery has not been done in my department. Open the joint, distract the facets, denude the cartilage, introduce bone graft, and realign the craniovertebral junction. We had also introduced these intra-articular spacers as a method of fixation of atlantoaxial joint and distraction of the facets. I must tell you now the indications of such distractors are very far and few in my series, but these are the spacers that we had described, and these have been quite popular in the craniovertebral junction surgeons. Rotatory atlantoaxial dislocation is quite a common clinical entity in children in particular. Adults do not have rotatory dislocation of that kind, and nobody in the world knew how to treat craniovertebral junction instability of this rotatory form. And so this article, you know, Alan Crockett had described some kind of treatment from lateral cervical, and there are some very isolated papers, but real atlantoaxial, open the joint, manipulate the facet, realign the facets, and you can give an absolutely wonderful new face to the child and new possibility of new, completely new neck. So you see there is a facetal malalignment, and there is a facetal realignment. Open the joint, manipulate both the facets at one time. The technical issues are, of course, quite elaborate and mentioned in my article, but there is a possibility of realigning the neck and giving this beautiful new neck to this child, and also a fantastic smile. I must tell you that all my patients, I have taken permission to show their pictures, so there is no issue in having this kind of visual impact. This is another case of rotatory dislocation. These children they come with just deformity. There is no pain, there is no neurological symptom. Open the joint, denude the cartilage, realign the craniovertebral junction, and you can give a very fantastic neck. And otherwise, you know, if you don't treat them, over the period of time, they can have several complications with the rest of their spine. This is another child with a rotatory dislocation. And also I have to mention that there is no other treatment. Of course, there is conservative treatment in a select group of patients, and before you do any treatment, conservatism may be an option, but inclusion of the occipital bone decompression is completely out of the sync. This is another handsome child, and you see the rotatory dislocation, and you see the child with a smile and with a straight neck that he can face the world in a very parallel fashion and eye to eye. Basilar invagination is also a very common clinical entity. I have to say that in the year 1998, I described this article where we have our own impression was, and the world's impression at that time was that basilar invagination is a fixed atlantoaxial instability. We described two types, odontoid going up and tonsil coming down. Transoral decompression for this and foramen magnum decompression was described in this article, which is highly cited article in this field. But then, of course, we treated basilar invagination by opening the joint, distraction of facet, and this formed an entirely new paradigm and a new revolution in the field of craniovertebral junction. And I will show you some images. You see, this is basilar invagination. This was a clear-cut case for transoral decompression. Open the joint, distract, no decompression from front, no decompression from behind, no decompression, realignment of the craniovertebral junction has become a norm, and many patients have gone through this kind of treatment. And I have no doubt that these patients will need craniovertebral realignment, selective atlantoaxial fixation, even in the situation of assimilation of atlas. No need to do occipital fixation. Opening of the joint is absolute mandatory. So this was my first case in the year 2000 where I had done distraction reduction and realignment of the craniovertebral junction. As you can imagine, transoral surgery was the name of the game for these kind of patients. So in my business of craniovertebral junction surgery, I have no hesitation to say that these techniques have completely relegated transoral surgery into the domain of history. Another fantastic thing that I want to share with you is that atlantoaxial dislocation, when it is chronic in situation, the facets may be in alignment, but they are unstable. It is like shoulder joint. It may be in alignment, but it is unstable. Many musculoskeletal and neural transformations occur, which are all secondary to atlantoaxial instability. You do atlantoaxial stabilization, there is a possibility of reversal of all these changes, which include short neck, torticollis, Klippel file abnormality, platybasia, You do atlantoaxial stabilization. In the evening of operation, the neck will become straight. There is no need to do any kind of osteotomy, which are described for this torticollis and this kind of situation. Nothing is required. Atlantoaxial stabilization is the key, and stabilization is a difficult procedure, but it is an absolute magical result that you will get after surgery. So all these kind of short neck, platybasia, torticollis, clipal file abnormality, assimilation of atlas, C2-3 fusion are all secondary protective maneuvering. What is required is difficult operation of opening the joint and fixation of the atlantoaxial joint, and you can give an absolutely fantastic neck posture and relieve him of all his symptoms. You have given a new child. Basilar invagination, you see the facetal malalignment, no matter how the facets are malaligned. But what is required is atlantoaxial stabilization, and you have a possibility of a fantastic clinical outcome. So this was my very early case where I had done atlantoaxial fixation for case of torticollis and short neck. You see the neck has become long, the neck has become straight, and there is no question that the patient has improved in the clinical symptoms. You see there is a rotation here. Early in my business, I used to distract on one side and realign, but I don't do distraction on one side. Just the answer is to do atlantoaxial stabilization. And this child, you see how the neck is on one side, and you see the wonderful smile in the very early postoperative stage when he had come for suture removal. Fantastic, you see, and he was also very happy with his treating doctor, and this smile is a gift to his doctor. You see the odontoid process is here, and odontoid process is right in the midline. It is not the way the odontoid will move, but the way the fixation is conducted will determine the neck of the person, the shape of the child, and the neurological symptoms. So this is another case of basilar invagination. So what I'm saying is all these kind of deformation are not anomalies. They are not embryological dysgenesis or fetal problems. They are acquired and they are secondary, and they can be reduced, more importantly, and they can be reduced in the immediate postoperative period. You see the neck is long and the smile is big, and the shape of the neck is changed, and the whole business of this person. And you can imagine that how happy the parents of the child must be. They have got a child who was probably not able to sit, probably not able to eat, and now he's walking on his own and is looking for a glorious future of his life. And the parents are absolutely happy. Cervical fusions, when they happen, are not anomalous. They are not embryological problems, but they are divine solutions for craniovertebral junction instability. Bifid anterior and posterior arches are dynamic. They move. When you do flexion, it closes. When it do extension, it opens. So it is a dynamic. Lateral dislocation is a dynamic phenomena in presence of bifid. So bone fusions and bifid, when there is bone fusions and there are bifid, these are not to be treated. These are not anomalous. They are indicators of atlantoaxial instability. They are absolute indicators to treat atlantoaxial stabilization. So multi-level fusion, there is no compression, but there is an absolute, there is indication of atlantoaxial instability. This child was a child of a very big newspaper man, and this was published in newspaper with my photograph very prominently, and instantly I became famous because this child was not able to breathe before operation properly. And in the evening of operation, she was sleeping in supine position, a position which was never taken in her lifetime. So there is a possibility of giving new life. Don't miss it. Don't miss it. Learn the technique of atlantoaxial stabilization. This was the child with the entire head coming on, and he's holding the chin to support his neck, and you do fixation. There is recovery. This patient, the only symptom is hyperextension of the neck. And you see the facets, one facet here, one facet here, and you do stabilization, you make the new life to this child, and you see the neck has become normal. So there is a big possibility. Os odontoideum is an entity very few people in this world understand. You see, I recently published this series of 190 cases. You know, those who are in this business know that many of the people will do transoral decompression. Several people will do occipitocervical fixation, which is an absolutely suboptimal operation. Open the joint, high vertebral artery, deal with the vertebral artery, fuse the joint, introduce, and you can give remarkable clinical recovery very early in the post-operative period. Os odontoideum with syringomyelia, chiari malformation does not need any kind of treatment. These are all natural protective maneuvering by nature to save the child from cord compression, and you need fixation. The syrinx will go. There's no need for decompression, syrinx, nothing. You need to do atlantoaxial fixation. Recently, my recent work is quite a powerful work. I have a feeling that I described 3 types of dislocation. One type is here. You see the facet of atlas in front of facet of axis. And this kind of dislocation, this kind of instability, and this kind of fixation. We described this as a lumbosacral listhesis a long time ago. For basilar invagination of this type, you see, I will say the whole world still will do foramen magnum decompression, but I have to tell you that foramen magnum decompression is not the treatment. There is an unstable atlantoaxial joint, and stabilization is the treatment. Facet of atlas is behind facet of axis, and even when the facet of atlas is in neutral position, the treatment, these are an unstable joint and need stabilization. So central atlantoaxial instability when the facets are in alignment. So basilar invagination is always associated, whether it is group A, whether it is group B. I publish a large number of series of patients, and I said that foramen magnum decompression is a completely historical operation, and basilar invagination needs atlantoaxial stabilization. Syringomyelia needs atlantoaxial stabilization. Chiari formation needs atlantoaxial stabilization. So atlantoaxial instability is the cause of chiari malformation, and atlantoaxial stabilization is the treatment. Foramen magnum decompression is a completely negative operation even for children. And in pediatric age group, I recently published my series with 33 cases with atlantoaxial fixation. Don't argue on this subject. Don't discuss this subject. My recommendation to all the young and old pediatric surgeons will be to learn atlantoaxial stabilization. There is a possibility of giving brand new life to these children with chiari, with syrinx, atlantoaxial stabilization. So this is the child who recovered remarkably after atlantoaxial stabilization. No decompression, no decompression, only atlantoaxial fixation. The syrinx will reduce quite 100% after 1 year. And in several cases, even in the immediate postoperative period, you see the facetal instability is the issue. Motor evoked potentials can recover during operation. You do fixation, atlantoaxial and motor evoked potentials recover in the evening of operation. Spinal kyphosis with chiari malformation and syringomyelia, you know this entity is quite a common entity. CZ kyphoscoliosis, you don't need to do any treatment here. You don't need to do any treatment here. What you need is atlantoaxial stabilization. And of course, there is a possibility of recovery of the scoliosis in very quick time. This is another child with chiari, with syrinx, atlantoaxial fixation, and you see there is no treatment done to the kyphoscoliosis, no decompression, and completely supple and mobile spine. So central or atlantoaxial dislocation is a completely new paradigm to the scheme of atlantoaxial instability. One has to learn and understand this. Even there is no compression, presence of bifid is an indicator of unstable spine. This child has been given new life when there is no compression at the craniovertebral junction by this entity of central or axial, atlantoaxial instability, majority of these things happen in children. You see these wonderful, handsome boys, you see the smile on this child, you see the divine straightening of the neck, and you see the most fantastic smile that you will ever see. And you see this posture of this child, which we all long to have in our lifetime. I call it the king posture. So the king issue in spine is atlantoaxial instability, and the king treatment is atlantoaxial stabilization. Thank you very much, my dear friends. I hope I have been able to give some new information to all of you. I hope this may be useful for the people who are doing all these kind of things. Thank you very much.
Thank you so much, Professor Goel.
Girish, my friend, thank you. I hope you enjoyed it, Girish.
I absolutely did. And you've got quite a lot of questions. If you release the screen, I'm going to put some questions for you now.
Yes.
We have a lot of time, so I would be very grateful if you could just give brief answers.
Okay. Okay.
Can you see the screen? I'm not sure whether you can see the screen.
I can see the screen. Can you ask me the question, Girish?
Yes. Let me just. Oh yeah. So the thing is disabled. Okay. So what I'm going to do is I'm just going to ask you the questions. The first question, of course, the important one. It demonstrated the presence of. You showed that you have been able to do fixation with very young children, 8 months old, using screws. Are these special screws? Because in Europe and the US, I think we don't have screws big enough small enough for children under 1 year of age. And also,
No, these are not very special screws, Girish. These are very straightforward screws, and they are readily available in India. And if something is available in India, I'm sure it will be available elsewhere. And there are companies making in India these screws, and these are titanium screws. Early in my career, 30 years ago, 32 years ago, I was using stainless steel. And for a long time, I used stainless steel. And I used to use radio ulnar fixation plates earlier in my career. But of course, now I have beautiful titanium materials, material. And these implants are named on my names. So they are named as Goel implants. So if you are interested, I can send some to you, dear Girish.
Absolutely. With are these 1 millimeter, 2 millimeter, 3, 3.5, 4?
No, they are, in children, they are 2.5 or 2.6. And in adults, they are not very big like polyaxial screws, and they are 3.4, 3.6. My screws are for adults, they are about 2.8 to 3 millimeters in thickness. And in children, it is 2.5, 2.4. I have all kinds of, permutation combination in my theater. But the length is about 24 millimeter, 22 millimeter in children. In adults, it is about 26 millimeter.
Excellent. Okay, another very quick question about atlantoaxial rotatory subluxation. There are lots of other questions on the chat. Perhaps you could answer directly that. But on the patients with long-standing atlantoaxial rotatory subluxation where the bones are fused, do you go and drill the facets, the fused facets, and realign them?
No, if the bones are fused, then don't touch it. If the bones are fused, you see, but what will happen is rotatory dislocation is a dynamic process. It never fuses. The joint will never fuse. It is extremely rare that I have got several patients of long-standing rotatory dislocation, which I have recently published also. The joint will never fuse. So you have a possibility of opening the joint, but if it is fused, if there is bone formation, then of course, don't touch it.
Okay, that's very helpful. Thank you so much, Professor Goel. I'm going to pass the control to Mania for the next presentation. And thank you again for this stellar.
Thank you very much. Thank you, Naren. Thank you, Girish. And thank you, the entire team of your hospital. Thank you very much. Bye-bye.
Thank you, Professor Goel.
Thank you, Dr. Go. I'm going to introduce Hannes Haberl. He's a professor at the Department of Neurosurgery at the University of Bonn in Germany. And the title of his talk is Cinderella's Slipper, and it will be about how the selective dorsal rhizotomy, the journey of the selective dorsal rhizotomy into the limelight. So go ahead, Dr. Haberl.
Thank you very much.
Pavel, do you want to share your presentation, please?
Hannes, have you got the presentation, or is Lauren putting the presentation up?
I have a presentation, but yes, here. I hope it comes.
Sharing the screen. Do you need to get access to sharing the screen?
Dr. Haberl, there's a green button that says share screen. If you, great, thanks.
Okay.
Yes. So, can you see the presentation?
We can.
Okay, so thank you very much for the introduction. Despite this maybe a little bit confusing title, which I will comment a little later, the talk is still about SDR. Most of the content of this talk has just been published in this new edition of Neurophysiology in Neurosurgery, which contains a full chapter about SDR. In this chapter, I had the opportunity to rewrite a little bit the history of SDR, which is commonly misinterpreted. And these over and over cited prejudices about the early history of SDR is also the reason why I choose the title Cinderella Slipper for this talk. But let me come back to this later. Cerebral paresis is a heterogene group of movement disorders due to an early cerebral injury. Location, type, and extent of the injury decide on the treatment options. SDR is preserved for patients with a predominantly spastic movement disorder like the two ladies on the screen. SDR should be performed as early as possible.